Well, good morning, everybody. My name is Bernard Keavney. I'm British Heart Foundation Professor of Cardiovascular Medicine in the University of Manchester and the academic lead for the cardiovascular domain. Cardiovascular disease is the #1 cause of death worldwide. And as you've already heard, in Greater Manchester we have a particular problem. Our outcomes are the worst in the country. So what is our domain going to do about this? Well, through improving the organisation and delivery of cardiac and vascular care in Manchester, through leveraging some of the excellent basic science that we're doing in the university and turning that into new treatments for patients, and through training the next generation of outstanding cardiovascular scientists and physicians and surgeons and allied health professionals in Manchester, in words of one syllable, our aim is to bridge that gap. We have very substantial resources with which to do this. Within the university, we have internationally leading research groups conducting basic research on cardiac physiology, vascular biology, pathophysiology of stroke, and cardiovascular genetics. We have, as you've heard, 2 outstanding centres of excellence for providing tertiary cardiovascular care, which is comprehensive, including such things as transplantation and pediatric and adult congenital heart disease. Our hugely successful MAHSC stroke effort is centred around Salford Royal Hospital, which hosts an NIHR hyperacute stroke research centre. So I'm going to take you now briefly through some of our objectives for the next 5 years. Ben Bridgewater is going to tell you shortly about the work that he has led using transparency of outcomes to drive improvements in patient care in cardiac surgery. The 2 centres together already provide the largest service providing primary angioplasty for acute heart attack in the country. And one of our goals is to expand that by continued collaborative working to provide early specialist treatment to Greater Manchester patients who present with a threatened heart attack in collaboration with the Cardiac Network within 24 hours. We know from research that it is absolutely critical to provide rapid early treatment in an expert centre for these patients to maximise beneficial outcomes. We know from research that was carried out by Professor Pippa Tyrrell and her colleagues that if we optimised stroke care in Manchester such that we could offer treatment with clot-busting drugs to appropriate patients within the first 24 hours of their presentation with a stroke, instead of only within the first 4 hours, we'd save 50 lives a year. And I'm happy to say that through partnership within MAHSC and outside to other NHS providers in Greater Manchester, this reorganisation is in the process of taking place and should be achieved next year. So we will be saving some lives very soon. Within the university, we have excellent basic science, some of it led by our president, Nancy Rothwell, but also in heart failure, that has delivered knowledge about new molecules, new therapeutic targets in stroke and in heart failure in particular. So we intend to bring these discoveries to the clinic. For example, in stroke, there are already phase 2 studies going on of IL-1 receptor antagonist as a treatment to minimize neurological damage following certain types of stroke. Atrial fibrillation is a disordered heart rhythm of the chambers at the top of the heart, which is a modern epidemic. It is related to population aging and to the high prevalence of elevated blood pressure. Atrial fibrillation causes 20% of strokes, and the problem with it is that it's very often undiagnosed. So by using novel technologies, including one that was invented right here in Manchester by a consultant at Central Manchester Hospitals, we intend to empower general practitioners to make more diagnoses of atrial fibrillation in the community and reduce the morbidity and indeed mortality due to atrial fibrillation-related strokes. Inherited cardiac conditions are the commonest cause of sudden death in young adulthood. Although the conditions are individually rare, if you put them all together, about 1 in 250 people has an inherited cardiac condition. Now, in Manchester, we already have established expertise and excellence in genetic medicine, and we're going to put that together with the clinical services for inherited cardiac condition patients in the 2 tertiary centres, and with the excellent research in cardiovascular genetics that we're conducting in the University Institute to provide integrated, research-driven care for these families. New technology in genetics enables us to, it has revolutionized really the research that we can do together with these families and potentially the care that we can provide them. So our aim in 5 years is to become one of the internationally leading centers for the research and treatment into these conditions. Thank you for your attention, and I'll now hand over to Ben to tell you more about transparency.
Thanks very much. It was very interesting to hear the day announced by Mark this morning with the talk about Professor Semmelweis, because that was an early example of somebody who tried to look at comparative outcomes and obviously had a disastrous ending. He's not the only person who had that experience. Florence Nightingale was very much involved in league tables. She obviously did well. Ernest Codman did exactly the same thing in the States, and that was a complete disaster. But actually, what we're moving towards now is a much more transparent world, much more accessible information, and actually in health that's applying too. So what I want to start off with is to ask you some relatively simple questions to try and make that point. So if you could always...
quiz! Hooray!
If you can, this is a festive event, so if you could all give me an answer on that one. How many of you used the internet to purchase Christmas presents this year? I've used it to buy some, used it to buy most or all. I've bought presents but not used the internet. I have not bought any presents. How are we going? 125, 130? Give you another couple of seconds. Okay, we'll cut it off there then. Let's see there. So 35%, 39%, so over 70% have used it to buy some or all. There's a few of you got to get shopping. Okay, second question. When you use the internet, do you take notes of reviews, TripAdvisor, eBay, celebrating product reviews? Okay, answer now, please. Okay, we'll see how we go with that. I take some notice, 63% is the big score. I take no notice, 2%, that's very low. So it's interesting. Actually, you look at that, that's what we do every day. What do we do in health? We don't really do that at all. Why don't we do it? Because the information doesn't really exist to support that process. So that's to sort of set the tone, if you like. So why do we now report cardiovascular and other outcomes in the UK? Well, it's actually the recommendations of 2 public inquiries. The first public inquiry was Professor Sir Ian Kennedy's report published in 2001, where he said this stuff should be reported. Actually, exactly the same recommendation has come up from the Mid-Staff's report, and one of the things that he says in that is actually these recommendations came out before, but nobody took any notice of them, which is why Mid-Staff's happened. So some of his recommendations are about reporting outcomes for individual surgeons. So that came out last year, and the government's initial response to this was, this has had a beneficial effect in cardiac surgery, it will now happen for everybody else. So it's not happening for everybody else, but it's now happening for 13 different specialties, and it was the second iteration of that publication this year, and that's what I'm going to talk about in a little bit more detail. That's Honora O'Neill, who's a philosopher, and if there was ever an example which demonstrates that MAHSC has been a success, I think it's a cardiac surgeon showing you a philosophy side, so that's progress. So if you just want to read that through, we need trust. Trust is hard. We see untrustworthy actions, so how does that affect things? People are intelligent. The vast majority of consumers of healthcare are intelligent. They are intelligent users. And I think the key to this is being trustworthy. So the challenge now for the profession, the challenge for hospitals, is to demonstrate your trustworthiness. And one of the ways of doing that is with transparency, but it needs to be done with appropriate transparency. This was Sir Bruce Keogh, who is the father of the transparency agenda in this country. And he says, and I believe this, you have a moral responsibility to publish this stuff. But if you're going to do it, you've got to do it right. Because if you don't do it right, it can have all sorts of terrible adverse consequences. So this is just the website which was launched a couple of weeks ago. So this is a subset of NHS choices, My NHS. And the idea is to make this data easy for people. So if you type in consultant outcomes and you search in Google, the top one there is the NHS Choices site. So if you click on that, it's just loading there. So that gives all that stuff. Those are the specialties out there. We could look at endocrine, thyroid, lung cancer, vascular, but we'll look at adult cardiac surgery since there's some cardiac surgeons around. So you can search. So this is typing M20, and that'll just find you all the surgeons working in the city. So if we scroll down on that, that's a list of people who are currently doing surgery in this city. And actually, there's me at the bottom there. It tells you how many operations I've done. It tells me my results are okay. And actually, if you want to link through to the source information, that's available here. So this is the number of type of operations. This is exactly what I do. Coronary artery surgery, some aortic valve surgery, some mitral valve surgery, which is my specialist interest. And that's out there, and you can compare that to everybody else. This is my risk-adjusted in-hospital mortality. So this is a funnel plot, the way we like to display it. So on the y-axis is the risk-adjusted mortality, the number of operations. That's the sort of confidence interval. Green line is average, red line would be, above the red line would not be good. And again, more information. So this describes in more detail the exact profile of all the patients that I do. So that's now available for all cardiac surgeons, and actually all those other surgeons that I've shown there, about 5,000 of them in total. So how does this all work? Well, all the hospitals collect the data according to a standard format, and they submit that to an institute called the National Institute for Cardiovascular Outcomes Research, which is actually hosted within UCL, and we have very close relationships with them. That data is then extracted from there, and all the clever stuff happens up here. And that's really a collaboration between South Manchester, the university, and particularly Northwest eHealth and the FAR Institute. And then we have various outputs which come out, of which some of the things that I've shown you already are an example. So how do we do that? Well, we define the outcome. We set a standard for performance. We define acceptable and therefore unacceptable performance variation from that standard. You obviously have to go through a careful process of validating all that data with the units, and then we notify people as their results and we publish that stuff. And I guess this is the fancy stuff, if you like. So to do that, we need to adjust for case mix, and we do that using quite complicated algorithms. You need to calibrate for contemporary performance, and I'll come back to that. You need to understand the limitations of your risk models. We use funnel plot methodology, and then you do some other fancy stuff around the comparisons. So this is just a sample of the academic output that we've had to do this, because if you don't do this right, you can get these misleading comparisons, and there's quite a lot of fairly heavy stats and science in this to do this, and these are the kind of things we've been putting out over the last couple of years. So what this shows is improvement in quality. So actually there are about 700 people less dying today than would have been dying a decade ago after making adjustments for risk off the back of improving quality over time. So the red line at the top there is the expected mortality, and the black line there is the decreasing mortality. So what you've got is an improving observed to expected mortality ratio. Things are getting better. And one of the troubles that we have in making these comparisons is comparing things to a moving target. And we have to understand that moving target, the dynamics of this all, to actually get this stuff right. Similarly, when you're making these comparisons, you need to compare a surgeon who does predominantly high-risk surgery with a surgeon who does predominantly low-risk surgery. And if you don't do that, those comparisons are not fair, and that has adverse consequences. So we've done a bunch of stuff about making sure the risk models are right for that. Can we just play this one? So this is a pretty simple thing, and the reason I like this is because it's free. So this is basically, we took all the data, we used R, which is free source software, and we used Google Charts software to do the stuff. So this is a chart of risk-adjusted mortality over time. So each of those blobs is a hospital. The big blobs that do more volume, the smaller blobs are smaller hospitals. And you can see kind of natural cause variation, things bobbing up and down. But what you can see also is some of these hospitals kind of shooting out of the pack. And actually that's what we're looking for. We're looking to try and provide information from this data which enables people to monitor their practice. So again, if you look at that, that's my hospital, sort of bobbing along the pack. But you see some of these guys screaming off the top. And they need to know about it soon. They need to understand why that is. And they need to put action in place for sorting that stuff out. So that's one example, and I think the way this will be going for us is rather than having big, clunky IT projects, we will be having these rapidly deployable open source products actually giving benefit to the data. And this is something that we've done using the same data but giving an iPhone app, and this plays into the sort of empowerment of patients and the personalized information stuff that we were talking about before. So this app, which is freely downloadable, gives you an ability to search on particular operations. So this is an example of somebody who needs an isolated coronary artery operation, a man between the ages of 50 and 70 with an intrinsically good heart. And we know in the last 4 years there were 16,000 of those people, and their mortality was 0.4%. Their one-year mortality was 1.5%. So this would be a patient who has choices. They can have a conventional coronary artery operation. They could have a interventional cardiology procedure, and this sort of information gives them better data on which to make their choices. And it is their choice, and we need to support that choice using this kind of tool. This is another example. This is a different sort of patient, an elderly lady who's got an aortic valve problem. And again, there are not many of those people, so any prediction we can give them has much less power than before. But again, their mortality is 9%, their one-year mortality is nearly 20%, and this is the sort of patient we would probably be looking for an interventional cardiology procedure for, assuming they were suitable for that. But it would be their choice, and we need to support that choice. And finally, this is somebody, again, who has choices to make, somebody who's got mitral valve disease but hasn't got any symptoms. The jury's out on whether they're best having surgery or waiting until they develop symptoms, and actually you can use this sort of information to give them better help in terms of making that choice for themselves. So the NHS transparency is developing. We've shown the 5,000 or so surgeons in which this applies to well, and the challenge now is to work out better transparency metrics, both for organisations and for all doctors. MAHSC here, we have been central to developing this stuff. It provides useful information which is driving service configuration as well as driving service quality. It's starting to support personalised medicine in that kind of way, and all this data is feeding into regulation. This stuff can be very dangerous if you don't do it right, and if you listen to Honora Neal's stuff about transparency, she kind of buys into transparency. She says if you don't do it right, it can be dangerous. So the onus is on us to get the science right and support that. But what we're starting to see already is it's changing the doctor-patient relationship. People are challenging me in a different way to the way they were challenging me 10 years ago, and that is something I embrace and I think is something that's really good. What will also come out of this is results not being as good as they should be, which will also challenge the healthcare management teams. And what I'm hoping to see through MAHSC is actually people in these different domains, some of which are science, statistics, IT, social science, actually all supporting this agenda, because it's going to be a big changing issue in the next few years. Thank you very much.
Thank you very much indeed to both of you. I did want to talk to you about that red hospital that's going off the top of the... Which one is that, actually? Just.
Are you talking about the last red hospital?
Well, there were a few bouncing up. I'm just worried. Well, actually, it's a sensible question in one sense, which is actually at what point do you think it's your responsibility to say, oh, they're not doing so well over there, somebody ought to go and have a look? It
is my responsibility, and this is something we call the Paxman test. When a high-profile journalist asks you that question, how you deal with it. But I'm now going to officially change its name in our world. But that was Brighton, okay? That last hospital was Brighton, and if you go onto the website, which many of you could do right now, they will say that our results weren't very good 2 years ago, and we flagged it up, but they will also say we've done a whole bunch of things around that, and our results are now very good, and these are our results for the last year. So I think that's an example of this thing working. And actually, it's been quite uncomfortable to say this is a hospital. That's the sort of question which would have been ducked a few years ago, but that's the answer, and I think that's transparency working.
The other thing is about the complexity. That actually, you made the point that the data we might have. Magdi Yacoub famously, if you put him on that thing, a lot of his patients are dying, but that's because they were among the most difficult patients and high-risk patients that were going under his scalpel. How do you ensure that when the public see this stuff, and it seems to me absolutely right, patients should be able to have access to understandable data, that they can, get the complexity of that?
Yeah, I mean, that's an important question, and there's good science in this. We work very hard on that. But the way I look at it is all models are wrong, but some are useful. Okay? And the model that we use is useful, but say Magdi Yacoub's results were worse than they should be, on that sort of analysis, that doesn't tell you anything. But what it does tell you is you need to look in more detail. Because even the fact that he was famous and world-renowned and everything, were his patients always getting the best deal? And you can only know that if you look in detail at his practice.
And presumably, Bernard, I mean, what you're doing in terms of this kind of stuff has, well, you've just been talking about it, I mean, has the possibility of being rolled out. across all the domains that we're talking about today.
Yes, indeed. Well, in interventional cardiology, it already happens. So the outcomes for individual interventional cardiologists are also published. But I have to emphasise what Ben said about the core role of MAHSC and the statistical expertise and the importance of doing this right, because as somebody whose outcomes have been reported on, I feel a degree of nervousness in case that it might not be done correctly.
And actually, it's really important that MAHSC has the confidence as a body to move this forward, because there'll be lots of people who are saying, not sure I really want to go there. I don't want people to be looking too closely.
It absolutely is, and trust is key here. Yeah. The people who are being reported on need to have trust in the people who are doing these complicated analyses and producing these results.
Thank you both very much indeed, gentlemen. Ben Bradshaw and Ben Bridgewater and Bernard Keavney.